September 26, 1916. Captain Thomas Hartley, Royal Army Medical Corps, crouched in an aid post 300 yards behind the front line, hands covered in blood that wasn't his own. Before him lay Private William Morrison, 19 years old, left leg shattered by shrapnel, bone fragments protruding through torn flesh. Hartley had no anesthesia except rum, no antibiotics because they didn't exist, no blood for transfusion, no X-ray to see the full extent of damage. He had morphine for pain, iodine for disinfection, and a bone saw for amputation. Morrison screamed as orderlies held him down, the rum doing little to dull agony as Hartley worked. The surgery took 12 minutes, performed by flashlight in a dugout that smelled of earth, blood, and gangrene. Morrison would survive the amputation but die 3 days later from gas gangrene, the infection that killed more wounded soldiers than the wounds themselves. This was Great War medicine. Brutal, primitive, often futile. Doctors worked miracles with inadequate tools, saving some while watching others die from infections they couldn't prevent or treat. 28 years later, on a beach in Normandy, another generation of medics would have sulfur drugs, penicillin, plasma for transfusion, rapid evacuation by air, and survival rates that would have seemed impossible to Hartley as he watched Morrison die from wounds that World War II medicine would render survivable. The Great War began with medical practices barely advanced from the 19th century. Germ theory was understood. Antiseptic surgery was practiced, but the tools and techniques for treating massive trauma in battlefield conditions were primitive. The scale of casualties overwhelmed medical services designed for much smaller conflicts. The nature of wounds, caused by high explosive shells and machine guns, exceeded anything doctors had trained to treat. The result was medical catastrophe, thousands dying from wounds that should have been survivable, infections spreading unchecked, suffering prolonged beyond what medicine should have permitted. The aid posts closest to Frontlines were makeshift facilities in dugouts, ruined buildings, or tents, positioned as close to the fighting as safety permitted. These stations provided first aid only, stopping bleeding, splinting fractures, administering morphine, applying field dressings. The medical officers who staffed these posts worked under constant danger from artillery, with minimal equipment, treating wounds in conditions that violated every principle of sterile surgery. They sorted casualties, deciding who could be saved and who was beyond help, a triage process that saved some lives while condemning others. The journey from aid post to field hospital was itself often fatal. Wounded men were carried by stretcher bearers through communication trenches, a journey that might take hours, every bump and jostle causing agony. The stretcher bearers, often conscientious objectors serving in non-combat roles, performed heroically dangerous work, carrying wounded under fire, sometimes dying alongside the men they tried to save. The delay between wounding and surgical treatment meant that wounds became infected, bleeding continued, shock deepened. Many men died during evacuation, who might have survived with faster transport. The field hospitals, positioned miles behind the lines, provided the first real surgical care. These facilities, established in commandeered buildings or large tent complexes, had operating rooms, surgical equipment, and trained surgeons. But they lacked many essentials of modern medicine. There was no reliable way to replace lost blood. Antibiotics didn't exist. X-ray equipment was rare and primitive. Surgeons operated based on external examination and experience, unable to see internal damage without opening the body. The surgical techniques were brutal by necessity. Debridement, the removal of dead and damaged tissue, was performed aggressively, often requiring removal of large amounts of tissue to prevent infection. Amputations were common, performed when limbs were too damaged to save or when infection threatened to spread. The surgery was performed quickly, under time pressure from continuous arrival of new casualties. Surgeons worked for hours or days without rest, operating on dozens of men in succession, maintaining technique and judgment despite exhaustion. The anesthesia available was chloroform or ether, administered by dripping onto gauze masks held over patients' faces. This provided general anesthesia but was dangerous, sometimes killing patients through overdose or respiratory depression. There was no way to monitor depth of anesthesia precisely, no equipment to support breathing if patients stopped breathing on their own. Anesthesiologists worked by observation and experience, watching breathing and colour, adjusting anesthetic by guesswork. Some patients died from anesthesia rather than wounds, adding to the toll of medical limitations. The infection problem dominated medical concerns throughout the war. Wounds became infected almost universally, contaminated by soil, clothing fragments, and bacteria. Gas gangrene, caused by Clostridium bacteria that thrive in oxygen-poor tissue, was particularly deadly. The infection spread rapidly, producing gas bubbles in tissue that crackled under fingers, a sensation doctors learned to dread. Treatment required radical surgery, removing all infected tissue, often requiring amputation to save the patient's life. Many patients died anyway, the infection progressing faster than surgery could control it. Tetanus was another killer. The bacteria entering wounds from soil, causing muscle spasms so severe they broke bones, respiratory paralysis, and death. The development of tetanus antitoxin during the war reduced deaths significantly. One of the few medical advances that made immediate impact. Soldiers received antitoxin shortly, after wounding, providing passive immunity that prevented most tetanus cases. This was genuine medical victory, demonstrating what was possible when prevention could be deployed rapidly. The lack of blood transfusion capability meant that soldiers who bled heavily died from shock and blood loss, even if wounds were otherwise survivable. Doctors understood that replacing lost blood would save lives, but the technology didn't exist in practical form. Blood typing had been discovered in 1901, but transfusion required direct person-to-person transfer, impractical in battlefield conditions. Some experiments with citrated blood, which could be stored briefly, showed promise late in the war, but widespread transfusion wouldn't arrive until World War II. The pain management was limited to morphine, administered by injection. Morphine was effective, but created dependency, and supplies were sometimes inadequate for the scale of suffering. Wounded men waited hours or days for surgery, experiencing continuous pain that morphine only partly relieved. The psychological trauma of prolonged suffering, combined with horror of injuries and fear of death, created mental health crisis that military medicine was unprepared to address. The shell shock problem emerged as war progressed, soldiers breaking down psychologically under sustained combat stress. The medical establishment initially dismissed these cases as cowardice or malingering. Gradually, doctors recognized that psychological trauma was a real medical condition requiring treatment. The treatments offered ranged from rest and counseling to electroshock therapy and other brutal interventions. Many shell shock victims were simply returned to Frontlines, where they broke down again or were killed. The understanding of combat trauma was primitive, the treatments often ineffective or harmful. The gas warfare introduced new medical challenges. Chlorine, phosgene, and mustard gas caused injuries doctors had never encountered. Chemical burns to lungs, blindness, skin lesions that wouldn't heal. Treatment was largely supportive, trying to keep patients alive while their bodies healed or didn't. Gas masks provided some protection, but many soldiers were gassed before they could don masks or by gases that penetrated protection. The gas victims who survived often had permanent disabilities, lungs scarred and breathing compromised for life. The evacuation chain from front to rear was long and often lethal. Wounded men moved from aid post to field hospital to casualty clearing station to base hospital, each move requiring transport, each delay allowing infection to worsen. The British system in France moved casualties from front lines to England, crossing the Channel in hospital ships. This long evacuation meant men might spend days travelling while wounded, increasing infection risk and suffering. The system worked better than any previous war had managed, but was still primitive compared to what would come. The medical personnel faced impossible conditions. Doctors and nurses worked under fire, in facilities that were barely functional, with equipment that was inadequate. The nurses, mostly female volunteers, provided crucial care despite official military establishment that often dismissed their contributions. The medical corps soldiers, stretcher bearers, and orderlies performed dangerous work with little recognition. The chaplains who attended dying men provided spiritual care that medicine couldn't offer. Together, these personnel did extraordinary work with insufficient tools. The survival statistics showed medical limitations starkly. Of soldiers wounded in the Great War, approximately 1 in 8 died. The ratio varied by wound type and location, but overall, mortality from wounds remained high by later standards. The main killers were infection, shock from blood loss, and head or chest wounds that exceeded surgical capacity to repair. The medical system saved many who would have died in earlier wars, but lost many who later medicine would save. The amputees numbered in hundreds of thousands, men who lost limbs to wounds or infection. The artificial limbs available were primitive, heavy wooden or metal prosthetics that barely functioned. The rehabilitation was minimal. Amputees simply released with prosthetics and told to manage. The psychological adjustment to disability received almost no attention. Men expected to accept their losses without complaint. The amputee veterans became visible reminder of war's cost, men with pinned-up sleeves or wooden legs, marked permanently by service. Facial injuries were particularly devastating. High explosive shells and shrapnel caused horrific facial wounds, destroying features and leaving men unrecognizable. The surgeon Harold Gillies pioneered reconstructive surgery at Sidcup Hospital in England, developing techniques that would evolve into modern plastic surgery. But the results were primitive, men left with scarred, rebuilt faces that shocked civilians and isolated veterans. Many facial injury victims became recluses, unable to face society's reaction to their appearance. The chemical warfare injuries created a population of permanently disabled veterans. Men who had been gassed lived with respiratory problems, some requiring oxygen for the rest of their lives. The blindness caused by mustard gas left thousands unable to work or live independently. These veterans required long-term care that the government systems were unprepared to provide, creating social problems that persisted for decades. The psychiatric casualties, the shell shock victims, faced stigma and neglect. Many were dismissed as cowards, denied pensions, given inadequate treatment. The understanding of post-traumatic stress disorder was decades away. These men suffered nightmares, flashbacks, anxiety, and depression without recognition or support. Some committed suicide, unable to live with memories and symptoms that medicine didn't understand or treat effectively. The psychiatric toll of the Great War would only be acknowledged retrospectively. Then came the interwar years, 2 decades that transformed medicine through research, innovation, and technological development. The discoveries made during this period would revolutionize battlefield medicine, creating survival rates that Great War doctors would have considered miraculous. By 1939, when war returned to Europe, medical capability had evolved beyond recognition. June 6, 1944, Omaha Beach, Normandy. Lieutenant James Anderson, Medical Corps, worked in a temporary aid station 200 yards from the beach, treating wounded as they were brought from the assault. Before him lay Corporal David Miller, legs shattered by machine gun fire, bleeding heavily from multiple wounds. Anderson had tools his Great War predecessors could only dream of. Sulfur powder to prevent infection, plasma for transfusion to treat shock, morphine syringes for pain, rapid evacuation by amphibious vehicle to hospital ship offshore. Anderson sprinkled sulfur powder into wounds, started plasma transfusion through tubing connected to bottles hanging from improvised stands, injected morphine and applied pressure dressings. Miller was evacuated within 30 minutes of wounding, received surgery within 2 hours, and would survive wounds that would almost certainly have killed him in 1916. This was modern battlefield medicine. Rapid, sophisticated, effective, transforming wounds that once meant death into injuries that were survivable. World War II began with medical capabilities transformed from the Great War. The discoveries of the interwar period, particularly sulfur drugs, blood banking, and improved surgical techniques, meant that wounded soldiers had dramatically better survival chances. The United States military, learning from British experience and building on research, created a medical system that prioritized rapid treatment, aggressive infection prevention, and efficient evacuation. The results would show in survival statistics that exceeded even optimistic predictions. The sulfur drugs represented the first effective antibiotics, discovered in the 1930s and deployed widely by World War II. These synthetic drugs prevented bacterial infections when applied to wounds or taken orally. Combat medics carried sulfur powder in every first aid kit, sprinkling it into wounds immediately after injury. This simple intervention prevented the gas gangrene and other infections that had killed so many in the Great War. The impact on survival was immediate and dramatic, turning previously fatal infected wounds into manageable injuries. Penicillin became available during World War II, though initially in limited quantities. This natural antibiotic, discovered by Alexander Fleming in 1928, but not produced in quantity until the 1940s, was extraordinarily effective against bacterial infections. Penicillin saved soldiers who had developed infections despite sulfur treatment, curing pneumonia and sepsis that would have been fatal. The military prioritized penicillin production and distribution, ensuring that this miracle drug reached soldiers who needed it. The demand always exceeded supply, requiring triage decisions about who would receive treatment, but availability increased throughout the war. The blood banking system revolutionized treatment of shock and hemorrhage. The American Red Cross organized blood donation campaigns, collecting millions of units that were processed, typed, stored, and shipped to combat zones. The discovery that plasma, the liquid portion of blood, could be dried and reconstituted later meant that blood products could be stored and transported without refrigeration. Combat medics carried plasma in every aid station, starting transfusions within minutes of soldiers arriving. This immediate treatment of shock prevented deaths from blood loss, maintaining blood pressure and organ function until surgery could repair damage. The whole blood transfusion capability followed later in the war, as refrigeration and transportation improved. Field hospitals received shipments of fresh blood, allowing transfusion during surgery to replace losses. The blood typing system ensured compatibility, preventing transfusion reactions that had plagued earlier attempts. The ability to replace lost blood during surgery meant surgeons could repair wounds that previously would have been too risky, saving soldiers who would have bled to death despite surgical skill. The evacuation system was faster and more efficient than the Great War. Jeep ambulances moved wounded from aid stations to field hospitals over roads that engineers cleared and maintained. Amphibious vehicles evacuated wounded from beaches during island assaults. Most dramatically, air evacuation removed wounded from combat zones to rear hospitals in hours rather than days. The C-47 transport planes that dropped paratroopers returned, carrying wounded, flying them to hospitals in England or rear bases. This rapid evacuation meant wounds were treated definitively within hours, preventing infection and allowing aggressive surgery. The field hospitals were mobile surgical facilities that accompanied advancing armies. These tent hospitals had complete surgical capability. Operating rooms with modern equipment, X-ray machines for diagnosis, laboratory facilities for blood typing and testing, recovery wards for post-operative care. The surgical teams performed operations that civilian hospitals would have struggled with, working in tents and temporary buildings, but with equipment and capability that exceeded what Great War base hospitals possessed. The MASH concept, Mobile Army Surgical Hospital, wouldn't appear until Korea, but World War II's field hospitals were predecessors, mobile facilities providing advanced surgery close to fighting. The anesthesia had advanced dramatically. Sodium pentothal, introduced in the 1930s, provided rapid, safe induction of anesthesia. This intravenous drug put patients to sleep in seconds, was easily controlled, and had fewer side effects than ether or chloroform. Anesthesiologists were trained specialists who monitored patients continuously during surgery, adjusting anesthesia and supporting vital functions. The safety of anesthesia improved dramatically, deaths from anesthesia itself becoming rare rather than common. The surgical techniques incorporated advances from civilian medicine. Vascular surgery could repair damaged blood vessels rather than simply ligating them, saving limbs that would have required amputation. Neurosurgery could treat some head injuries, removing bone fragments and repairing damage to extent possible. Thoracic surgery treated chest wounds, removing bullets and shrapnel from lungs and hearts. The surgery was still challenging and many patients died, but the techniques and outcomes were vastly improved. The antibiotics transformed infection treatment. Wounds that became infected despite prevention could be treated with penicillin or sulfur drugs. Infections that would have been fatal becoming curable. The gas gangrene that had terrified Great War surgeons became rare, prevented by immediate sulfur application and treated successfully with penicillin when it did occur. Tetanus remained preventable through antitoxin. The infection that had been the greatest killer of wounded soldiers was brought under control. Not eliminated, but manageable. The pain management incorporated regional anesthesia techniques. Nerve blocks could eliminate pain from limbs, allowing surgery without general anesthesia or providing pain relief after surgery. Spinal anesthesia enabled abdominal and lower body surgery while patients remained conscious. These techniques reduced anesthesia complications while providing excellent pain control, combined with morphine and other analgesics. Pain management was sophisticated enough that soldiers didn't suffer the prolonged agony common in the Great War. The burn treatment advanced significantly, important for treating wounds from flamethrowers, burning vehicles, and aircraft fires. Fluid resuscitation protocols maintained blood pressure in burn victims. Specialized burn dressings protected wounds while healing occurred. Skin grafting techniques allowed reconstruction of burned areas. Burns that would have been fatal in World War I became survivable. Though recovery was long and painful, the burn wards treated horrific injuries with some success, though many patients still died from massive burns or infections. The psychiatric treatment showed evolving understanding of combat stress. The term combat fatigue replaced shell shock, reflecting recognition that combat stress was inevitable rather than sign of weakness. Treatment included rest, counseling, and gradual return to duty for those who could continue. The understanding remained incomplete, but was better than World War I's punitive approach. Soldiers who broke down psychologically received treatment rather than accusations of cowardice, though stigma still persisted. The prevention of disease became organized systematic effort. Vaccination programs prevented tetanus universally. Water purification prevented dysentery and cholera. Mosquito control programs reduced malaria in Pacific Theater. Penicillin could treat sexually transmitted infections, preventing the disability that had affected armies throughout history. The public health measures kept armies healthy, preventing the disease epidemics that had devastated earlier conflicts. More soldiers died from combat than disease, a reversal of historical patterns. The dental care was organized and effective, preventing tooth infections and maintaining nutrition. Field dental units traveled with armies, treating cavities and infections, performing extractions when necessary. This prevented dental problems from disabling soldiers, a mundane but important contribution to combat effectiveness. The attention to dental health reflected a comprehensive approach to soldier wellness. The nutrition was monitored and managed, understanding that well-fed soldiers healed better and fought more effectively. The rations provided adequate calories, protein, and vitamins. When soldiers were hospitalized, special diets supported healing. The connection between nutrition and recovery was understood and implemented, contributing to survival rates. The specialized treatment for specific injuries developed throughout the war. Maxillofacial surgery treated facial wounds with techniques building on Gilles's Great War innovations. Orthopedic surgery repaired complex fractures with pins, plates, and casts that previous generation couldn't have imagined. Ophthalmology saved vision in many cases, where blindness would have been inevitable. Each specialty contributed to overall improvement in outcomes. The air evacuation system became increasingly sophisticated. Specially configured C-47 with medical equipment and nursing staff flew wounded from forward airstrips to rear hospitals. The flight nurses who staffed these flights provided critical care during transport, monitoring patients and intervening when complications arose. The ability to evacuate critically wounded soldiers by air saved countless lives, moving patients in hours across distances that would have taken days by ground transport. The hospital ships provided floating hospitals that could position near combat zones. These ships, protected by Geneva Convention markings, had complete surgical facilities and carried wounded from Pacific Islands or invasion beaches to rear hospitals. The USS Solace and other hospital ships became legends, their white hulls and red crosses symbols of hope for wounded soldiers. The ships could perform major surgery at sea, stabilizing patients for longer, evacuation or treating definitively. The combat medics themselves were better trained and equipped than Great War predecessors. The American combat medic training lasted months, teaching anatomy, first aid, patient assessment, and evacuation procedures. The medics carried comprehensive first aid kits with sulfur, morphine, bandages, plasma, and instruments. They worked under fire to reach wounded, performing first aid that often meant difference between life and death. The medics earned soldiers' respect and gratitude, their Red Cross armbands marking them as saviors in combat chaos. The German medical system, sophisticated early in the war, deteriorated as German situation worsened. German doctors had excellent training and techniques, but lacked resources that Allied medicine possessed. Penicillin remained unavailable to German forces, sulfur was often in short supply, and evacuation became difficult as Allied air superiority prevented movement. German wounded received good care when resources permitted, but increasing scarcity meant outcomes worsened as war progressed. The Japanese medical system operated under different philosophy and constraints. Japanese military culture emphasized endurance and considered wounds shameful weakness. Medical care was often minimal, evacuation was low priority, and wounded soldiers were sometimes abandoned to die rather than burden units. The Japanese lack of antibiotics, inadequate surgical capability, and cultural attitudes toward wounded meant Japanese soldiers died from wounds that Allied medicine would have treated successfully. This difference in medical philosophy and capability contributed to casualty disparities. The Soviet medical system functioned under extreme pressure, treating millions of wounded with limited resources. Soviet medical personnel, many of them women, worked heroically under terrible conditions. The evacuation system was often inadequate, wounded sometimes waiting days for treatment. Resources were scarce, antibiotics limited, supplies insufficient. Despite these challenges, Soviet medical personnel saved many lives through skill and determination. Though mortality rates exceeded Western Allied forces significantly, the statistics told the story of medical advancement. In World War I, approximately 8% of wounded died. In World War II, approximately 4% of American wounded died, mortality cut in half. The improvement came from antibiotics, blood transfusion, rapid evacuation, and surgical advances. Wounds that would have been fatal in 1916 were survivable in 1944. The medical system had evolved from primitive to sophisticated in one generation. Abdominal wounds, usually fatal in World War I, had 50% survival rate by World War II. Chest wounds showed similar improvement. Head wounds remained often fatal, but some survived who would have had no chance earlier. Limb wounds rarely required amputation if circulation could be maintained. Vascular surgery saving limbs that would have been lost. The improvements were across all wound categories, reflecting systematic advances rather than single breakthroughs. May 8, 1945. Victory in Europe. The medical personnel who had served throughout the war had witnessed medicine's triumph over trauma. They had saved soldiers who would have died in any previous conflict. They had seen antibiotics cure infections, plasma reverse shock, surgery repair damage that once would have been irreparable. The medical advances of World War II saved hundreds of thousands of lives, wounded soldiers surviving to return home, to raise families, to live lives that would have ended in earlier era. The post-war impact of these medical advances extended far beyond military applications. Penicillin became available for civilian use, revolutionizing medicine. Blood banking became standard practice in hospitals. Surgical techniques developed for battlefield trauma improved civilian care. The training of thousands of medical personnel during the war created a generation of doctors and nurses whose experience improved healthcare throughout society. The medical system that saved soldiers in combat saved civilians in peace. The wounded veterans of World War II faced better rehabilitation than their father's generation. The artificial limbs were lighter and more functional. The rehabilitation programs taught amputees to walk, work, and live independently. The GI Bill provided education and training, allowing disabled veterans to build careers. The social support was better, veterans receiving recognition and assistance rather than neglect. The outcomes were better in every way. The psychiatric casualties received better but still inadequate treatment. Combat fatigue was recognized as a legitimate condition, but treatment remained limited. Many veterans struggled with nightmares, anxiety, and depression that wouldn't be recognized as PTSD until decades later. The understanding had improved from World War I, but the treatment still fell short of what veterans needed. The psychiatric toll of combat remained inadequately addressed. The comparison between wars was stark and quantifiable. A soldier wounded in World War I had 1 in 8 chance of dying. A soldier wounded in World War II had 1 in 25 chance of dying. The improvement saved approximately 300,000 American lives that would have been lost with World War I medical care. This was medicine's triumph, systematic application of scientific advances to reduce suffering and save lives. The transformation from World War I to World War II measured medical revolution, from primitive surgery in dugouts to sophisticated field hospitals. From watching infections kill helplessly to preventing and treating them effectively. From inability to replace lost blood to routine transfusion. From amputation as default to vascular surgery that saved limbs. From shell shock as shameful weakness to combat fatigue as recognized condition. Every aspect of battlefield medicine improved dramatically in one generation. In the end, the story told in medical treatment, from Great War's brutality to World War II's sophistication, captured science's victory over trauma. The doctors who worked in both wars would barely recognize each other's capabilities. So dramatic was the transformation. The medics who sprinkled sulfur powder and started plasma transfusions performed interventions their predecessors couldn't have imagined. The surgeons who repaired blood vessels and treated infections with antibiotics practiced medicine that seemed miraculous compared to earlier era. The wounded who survived because of these advances lived lives that depended on scientific progress that occurred in the interval between wars. The medical corps who served in both conflicts witnessed and created revolution in battlefield medicine, turning wounds that meant death into injuries that meant survival, reducing suffering, saving lives, proving that medical science could keep pace with weapons technology, that healing could match destruction, that even in war's horror, medicine could triumph.